Assalamualaikum everyone. I hope my screen is visible to all of you. Okay. So today our topic is neonatal guideline. As today's class, we will see that there are many neonatal questions that comes in AKP exam. It's almost 10%. If you say almost 10% of the paper 1 and 10% of paper 2 will be neonatal guideline topic. So this topic is very important for all of you. So there is a new book, Neonatal Guideline. I'll show you that book just after a few moments. That neonatal book, we did that class in our batch. And that is also a very good book, I must say. So you can read that book also, Neonatal Guideline. And if you already read the blue one, okay, let me show you the blue one. If you already read the blue one, no problem. You can read the new guideline, just topics, the few important topics. Let me show you the two guideline side by side so that you can, many people actually does not know that there is new guideline that came in the market. So this is the blue one. Previously, this guideline we read all, right? In our part 1 and in our AKP, we read this guideline. This one is the blue neonatal guideline. This is 2019 to 2021, right? So every 2 years, RCPCH actually publish neonatal guideline or pediatric guideline. So after 2 years, this came. So now the new guideline is green one. That is 2000. Can you see this, the screen? If you can't see the screen, let me know, okay? So this was the blue, now the green one, okay? Previously it was blue one, now it is the green one. So you can see, and there is some guideline that is changed, like there is addition of neonatal sepsis guideline, and there is addition of neonatal hypertension. It was not previously in the chapter. And cord clamping guideline, it was not previously a separate guideline. Now it is separate, cord clamping guideline. Temperature management, previously there was kangaroo mother care, but now they have managed temperature management. Then infection control, congenital and acquired. Then stroke, pediatric neonatal stroke. Okay, then chest percussion, how we do chest percussion. These are the new guidelines that came in this book. So what is the importance of reading guideline? Okay, number 1, you will get question from new guideline or neonatal guideline or pediatric guideline, number 1. Number 2, AKP has a bulk of question from neonatal guideline. And also in your clinical exam, previously when some teachers are very old fashioned, like 10 year, 12 year they passed, 10 year back, 12 year back, they used to say previously that there is no need of neonatal guideline in MRCPCH. This was when I was preparing for my exam. My seniors told that no need of neonatal guideline. Okay, but when I passed, I saw many questions coming from neonatal guideline. And after I passed, I saw that in clinical exam, every clinical like DCH, MRCPCH, you have now the neonatal guideline station, neonatal station. So in that neonatal station, you have to answer from the guideline. Okay. This is AKP question pattern. You can see this is AKP question pattern. In the AKP exam, it is different from the part 1 exam. AKP exam has 4 types of question. In the part 1 exam, we know we have 2 types of question, that is best of 5 and extended matching question. This is for part 1. Sorry, this is for part 1 exam pattern, right? This best of 5 and this extended matching question. Okay, you can open your mic and you can speak to me, okay, because chat is very difficult to answer in the meeting time. So better if you put your mic open and question me, okay? So this is question pattern best of 5. It is present in part 1 also for PENTAS. It is present in AKP also. Extended matching question, it is also present in for PENTAS and also in AKP. Now these two question types, last two, are only present in AKP examination. Okay, screen is not shared. Sorry. Can you see the screen? Can anyone confirm you see the screen?
Yeah, we can see the screen.
Okay. So last two pattern of question that is coming from n from many. What do you mean by n from many? N from many means there will be one question, but the answer will be many. I mean, 2 or 3 answers. Suppose there is a question, okay? And there is an answer A, B, C, D, E, F, G. When you see there is one question, but A, B, C, D, E, F, G, there are multiple stem, more than 5. Then you should understand the answer is not 1. The answer is more than 1. So they will ask you in the question, answer 2 best answer, 2 best answer, or 2 best answer or 3 best answer from this stem. You understood my point? So this is called n from many. That means one question, one single best question, but the answer is not single. Answer is like 2, 3, 4. Okay. This is n from many type of question. Okay. Now there is another type of question in AKP that is called multi-part question. What does it mean? Multi-part question. Multi-part question means there will be question number 3, stem 1, stem 2, and stem 3. What do you mean by stem? Stem 1 means they will ask you diagnosis of HUS, hemolytic uremic syndrome. They will ask you what is the investigation of HUS. Okay. Number 3, they will ask you what is the treatment of HUS. So this is one question, 3. Among these 3, question 3, there is 1 question, 2 question, and 3 question. And here answer can be A, B, C. So answer can be 1 or 2. You got my point? This is called multi-part question. That means in question number 3, there is 3 questions. Okay, this is called multi-part question. And that's why in AKP, the examination is very different than FOP and TAS. In AKP, there is 2 papers, paper 1 and paper 2. Paper 1 and paper 2, this is same. There is no difference between paper 1 and paper 2. Paper 1 can have X-ray, ECG data. Paper 2 can have X-ray, ECG data. Okay, so there is no difference between paper 1 and paper 2, but the question will be different. Question will be like, from paper 1, they can give you like 6 system, any 6 system. In paper 2, they will give you any 6 system. Suppose they are giving you endocrine, renal in paper 1, they will give you like cardio or respiratory in paper 2, but it is not fixed. It is not fixed. Any question can come in any paper. You got my point? And the pass mark. Pass mark is also combined. Suppose in paper 1, 50 question. In paper 2, also 50 question. Okay, so total 100 question. Pass mark is 75. This 75, who decide? This 75, RCPCH decide that this paper pass mark should be 75. Okay, this is a standard monitoring system. They have a standard monitoring system. They monitor and they tell you that this is the pass mark today of today's exam. So combinedly by both paper, if you got 75, you passed. Suppose in paper 1, you got 50, but in paper 2, you got 80. So overall, you got 130, right? And that is 75%, almost. Okay, so combinedly, if you got 2 paper, you passed. Okay, that's why passing rate of AKP is a bit high than the part 1, bit high. But AKP is very different exam than part 1, and time management, 2.5 hour. 2.5 hour in paper 1 and 2.5 hour in paper 2. This is 5-hour exam, total 5-hour exam. Trust me, the most important thing is time. In AKP part 1, whatever, in clinical, whatever. Most important thing is not how much you are answering. No, it is time management. Some student, they are very shaky, confused. So they answer 1, then they change it 3, then they again come, change it 2, like that. So if you do like that, repeatedly changing the answer, what will happen? Your time will be wasted. Okay, so don't do this thing. Just finish your paper, flag the question, come back again. This is the best technique for AKP examination. Finish your paper, paper 1, flag the question that you are confused, and then come back and then check again that what answer is correct, what should I do. Okay, so this is the technique of giving exam. This is the question pattern. Anyone has any confusion before I go to the main session? Anyone has any confusion or any question related to AKP? Today's session is not for part 1, so don't ask any question for part 1. Any question related to AKP? Okay, no question. That means you all are very, expert in this AKP question pattern, everything. Okay, very, very good. So now let us go to our EMQ. So this is a very, very common EMQ question in AKP. That is a EMQ, that is cardiology. It is a cardiology. Can you see the full screen? Please let me know if you can't see the full screen. Okay, this is a cardiology question. It is a different types of congenital heart disease like VSD, ASD, PDA. Okay, so from this cardiology question, they will give you 3 scenarios. Scenario 1, this is scenario 2, and this is scenario 3. Now from this three scenario, there are multiple answers, like multiple. You can see up to H is the option. So you have to choose any 3 from these options. It's not full, right? Okay, let me see the full screen. How to make it full? I don't know how to make it full. It is in my computer, it is full screen. Can anybody tell me, can you see the full screen of this?
We can see the full screen.
Okay, okay. So you can see the question number 1, right? Systolic murmur, 2/6 musical murmur. Now, can anyone confirm me? Grading, murmur grading 2, is it very high-pitched murmur or low-pitched murmur?
Low-pitched.
Low-pitched.
Yes, it is low-pitched murmur. Heard in the lower left sternal border, best heard when patient is lying. That means changing of the position is changing the murmur. So tell me, there are 2 types of murmur. One is pathological murmur, one is innocent murmur. If I change my position and the murmur is changed, is it pathological murmur or innocent murmur?
Innocent.
Innocent. Very good. Because pathological murmur will not change by changing of position. So it is not pathological murmur. It is a innocent murmur. And remember, thrill. What is the grading of thrill? 4.
Grade 4 and above.
Grade 4 and above. It is pathological or thrill. Any murmur which has grade 4, it is always pathological. It is never physiological or innocent. So grade 4 and above is always pathological. But grades below 4, like 1, 2, 3, it can be innocent murmur. There are at least 7, 8 types of innocent murmur, like venous hum, then pulmonary flow murmur. There are many innocent murmur. You have to know the types of innocent murmur. And this is systolic 2/6 murmur, heard in the lower left sternal border, best heard when the patient is lying. That means changing position is changing the murmur. So it is no doubt innocent murmur. Okay, if anyone has any doubt, they can ask. Next, pansystolic murmur, 3/6. Best heard in the apex of the heart and radiating laterally. Laterally means what? Who can tell me? Laterally means which area of the body?
Towards the axilla.
Axilla, very good. So what kind of murmur going towards the axilla? It is a pansystolic murmur towards the axilla. This is only one kind of murmur.
MR murmur.
MR murmur, very good. Mitral regurgitation. Here there is no option of mitral regurgitation. Did you notice? There is no option of mitral regurgitation. So what will be the answer? Now the students who know that pansystolic murmur radiating to the axilla will be mitral regurgitation, but there is no mitral regurgitation. Can you see here any mitral regurgitation? No. There is mitral insufficiency or mitral incontinence. This is another name of mitral regurg. So remember, disease can be one, but they can have multiple names. So that is also your knowledge. They are testing your knowledge that you know what do you mean by mitral incompetency or incontinence. Same thing, mitral incompetency, mitral incontinence, mitral regurgitation, same disease. Okay, so the answer will be mitral incontinence or mitral incompetency. Why? Who can tell me why? Because it is same as MR. MR murmur. Okay, so pansystolic murmur radiating to the axilla, best heard at the apex. Remember, apex is the area. Apex is the area where only the mitral valve located. So every kind of mitral valve murmur, like mitral stenosis, will be in the apex. Mitral regurgitation will be in the apex. Although mitral regurgitation murmur is pansystolic murmur, but mitral stenosis murmur is what? Diastolic, isn't it?
Mid-diastolic.
Diastolic murmur, yes, mid-diastolic. So although murmur type is different, but they produce from the same area. It is in the apex area. So it is any confusion in this question? Okay. Now, continuous murmur 2/6 heard on the infraclavicular area that changes with position. What is that type of murmur? See, if it is a PDA murmur, now maximum student will answer PDA. If it is a PDA murmur, do you think PDA murmur will change with the position?
No.
No.
So it is not a PDA murmur. You got my point? So the student, suppose I'm giving AKP exam. I went to the exam hall and I answered it PDA, continuous machinery murmur on the infraclavicular area. I was very happy. I came back home. I said, everyone, my exam is very good. But do you think my exam was really good? My exam was not good because I did not notice this line that changes with position. So some student will tell you, my exam was very good. I don't know why I failed. Because lack of knowledge. Okay, that's why you failed. So remember, if you fail, that means there is place for improvement. Okay, and RCPCH will always try to improve your knowledge by this kind of question, that you know a murmur which is changing with position is never pathological murmur. It is not a PDA murmur, although it is continuous murmur. Because venous hum is a continuous murmur, PDA is a continuous murmur. Can anyone give me any example of another continuous murmur?
Valve procession.
Very good.
AV fistula.
Very good. AV fistula, window, arteriopulmonary window, or BT shunt. They are also continuous murmur. Very good. So there are six type of continuous murmur in our body, not only PDA. Many student does not know that, right? So not only PDA. We finish EMQ. Was it very difficult for you? No, it was not very difficult, right? Very easy question. There'll be some 7, 8 type of answer, and there'll be 3 questions. This is called extended matching question. Now come to the single best. What is single best answer? All of this question today I discussed, that is from the neonatal guideline. So if you read neonatal guideline, you will answer all of this question. Now this is a very common exam scenario. Very common exam scenario. Newborn, 1 hour after delivery. What is the diagnosis? Who can tell me? Newborn, 1 hour after delivery. This is 1 hour. Baby is breastfeeding. What is the diagnosis?
Epidermolysis bullosa.
Very good. Why not this is SSSS, staphylococcal scalded skin syndrome?
Only 1 hour.
Only 1 hour. If they give you 1 day, then can it be SSSS?
No, late. Presentation late.
See, why not this is SSSS? Let me tell you, why not this is SSSS? Why it is epidermolysis bullosa? See the sharp edge. Can you see the sharp edge? See the total skin is red. Okay, it is not inflamed. It is not inflamed. It is actually very fragile blood vessel. You can see the blood vessel, internal blood vessel, dermal blood vessel, very fragile. It is not infection. Okay, epidermolysis bullosa is a congenital condition. Okay, it can happen even before birth. That's why this baby is 1 hour of age. Staphylococcal scalded skin syndrome, you will find skin. You will find skin here, not like this color. You will find skin. It will be Nikolsky sign positive. What is Nikolsky sign? The skin is separated from the dermis. The epidermis is separated from the dermis. And if you rub the area, the epidermis will come out. This is called Nikolsky sign. Okay. In SSSS, any bullous disorder, SSSS, or like suppose Steven Johnson, they have Nikolsky sign positive. But what happens in epidermolysis bullosa? Although the name is bullosa, but there are two varieties, bullous variety without bullous variety. Okay, this is not bullous variety. Although the name is epidermolysis bullosa, but this is not non-bullous variety. What happens here? The skin of the upper layer is absent congenitally. Okay, it is not cutis aplasia. Cutis aplasia areata is not like that much loss of skin. Okay, and aplasia cutis areata will be like a small one, not like this much big, generalized. But epidermolysis bullosa is generalized condition. Okay, so there are 3-4 neonatal skin condition, neonatal dermatology that is very, very important for your exam, like junctional epidermolysis bullosa. This is the answer of this question. SSSS, this is not the answer because baby is only 1 hour, baby is breastfeeding, he is not septic. Why not alopecia totalis? Because in alopecia totalis, the hair that will be absent. I mean, all the keratinized tissue, not only skin, the nail will be absent. The hair will be absent. See, you can see the nail here. You can see the nail here. You can see the hair. They will give you the full picture of the baby. You will see the hair. In alopecia totalis, the baby will have no hair, no nail. I mean, total keratinization problem. Okay, and it is not a septic baby, so it is not SSSS. It is not cutis aplasia because cutis aplasia occur mainly on the scalp, but it can occur in any part of the body, but it will be very small. It will not be generalized. And also it is not toxic epidermolysis necrosis because baby is not septic. So this picture is very common. So from this picture, we know that pediatric neonatal dermatology, okay, there are different types of dermatological question that is very, very important for AKP. Okay, any question from this? You should know, I'm telling you one thing, that during our exam, we read more and more picture from Google. Suppose Edwards syndrome, we see from the Google 10 times, 40 times, 10 times, 14, 20 times, same baby, like Edwards syndrome, how the baby look. Suppose Williams syndrome, how the baby look. Suppose RDS, respiratory distress syndrome, X-ray, how it looks. So Google is the best for pictures. Okay, you can see the pictures on the Google. You can see multiple picture of junctional epidermolysis bullosa, SSSS, cutis aplasia. It will increase your visual memory. Okay. Next question. So this was single best answer. Okay, this is radiological question. Okay, this is also radiological question. This question is
I have a question. Yeah.
sorry.
Yes. How can we distinguish between epidermolysis bullosa and congenital syphilis washerwoman hand? Because both can present at day 1 baby.
Very good question. But congenital syphilis is a spectrum of disease, isn't it? Like there will be snuffle nose. Okay, congenital syphilis baby will not be term. It will be IUGR. Here the baby is term. You can see it's a term baby. You can see the crease of the hand and everything. It's nipple area. It's a term baby, plumpy baby, isn't it? Congenital syphilis babies are usually IUGR baby. The mother is infected. So here you will see a very small, lean and thin baby, low birth weight. And you will see snuffle nose, rhinorrhea. It is very common. And you will see some bony problem that is called yes,
Should
there will be
be.
some bony problem. Like the tibial bone will be bowing, tibial bowing, right? Here the tibia
Yes.
is not bowing. So there will be many problems. Saddle nose deformity, tibial bowing, and snuffle nose. So congenital syphilis is not only skin problem. They have multiple problems. So by seeing the baby, we diagnose it is congenital syphilis. It's so characteristic, right? So that is different baby. But here, only skin problem. So we can say this is epidermolysis bullosa junctional. Okay, did I answer your question?
Thank you, teacher.
Yeah, okay. Thank you, welcome. So this is abdominal X-ray. See, this is also single-based answer. But this question can come as multi-purpose question. I'm telling you, multi-purpose question. I'm making it as multi-purpose question, okay? How I'm making it? Well, I'm telling you how I'm making it multi-purpose. Suppose this is the question of X-ray. Okay, this is the X-ray question. Abdominal X-ray, lateral decubitus position of a 26-week baby with abdominal distension. What are the two findings in the X-ray? So this is question number 1. Question number 1, multi-purpose question. What are the two findings in the X-ray? Who can tell me? See the X-ray, zoom it. What is the X-ray finding in this? Lateral decubitus position, it is a neonate, 26 week. From preterm baby.
Yes.
Yes, from preterm baby, which kind of X-ray you can suspect? Abdominal X-ray. Neck. Yes, necrotizing enterocollitis. Can you tell us?
Pneumoperitoneum.
Yes, very good. This is free air inside the abdominal cavity, right? Air is black color. This is pneumoperitoneum. Can anyone tell me other feature of this X-ray?
Pneumatosis intestinalis.
Very good. See, here there is a gas in the wall of the intestine. See, this is the gas of the wall of the intestine. This gas in the wall of the intestine is called pneumatosis intestinalis. Now, this is neck. No doubt, this is necrotizing enterocolitis. Can anyone tell me in which stage of the necrotizing enterocolitis there is gas in the abdomen? Which stage it is? It has 3 stages.
Stage 4.
It has 3 stages actually.
Stage 2. Stage 2.
Stage 2B.
Stage 3 actually. Stage 3 is advanced. Okay. I know most of you are here very talented, knowledgeable. You are doing training at different hospital. But you know, in MRCPCH, those training and those guidelines are not mandatory. Mandatory is NICE guideline. NICE guideline says there are 3 stages of necrotizing enterocolitis. Number 1 is suspected. Number 2 is clinical. Number 3 is advanced or perforation. Any gas in the peritoneum that is free, it is perforation unless otherwise proved. So which stage it is now? Again, necrotizing enterocolitis, which stage it is?
3.
Stage 3. Stage 3 is called what? Surgical or advanced. So here, what is the treatment? Is there any option of medical treatment in this stage, or you will directly refer to the surgeon?
Refer to the surgeon.
You have some medical treatment here. What is the medical treatment in advanced stage? Number 1.
Stomach decompression करेंगे NG.
Very good. NG tube suction, nothing per oral, and fluid electrolyte. Yes, nothing per oral, NG suction, stomach decompression, nothing per oral, and number 3, fluid and electrolyte balance. And most importantly, you have to refer this patient to the surgeon. Why? Because they need laparotomy. This is a candidate for laparotomy. So, what two finding we can see from this X-ray? Number 1 is free air in the peritoneum. This is the number 1, right? Number 2 is intramural air. Pneumatosis intestinalis. It is not intestinal obstruction. Number 1. There is no dilated bowel loop. Okay? This is not dilated. Dilated bowel loop is stage 1. It is not stage 1. Thickened intestinal wall, no. Situs inversus, no. So this is multi-part question number 1. Okay. Now the multi-part question number 2. I am coming to multi-part question number 2. Multi-part question 2. So multi-part question 2 will be, suppose, what investigation, suppose what, okay, I'll tell you. What is the immediate management? Okay, this is multi-part question 2. What is the immediate management? Now, there is option A. Option A is call the surgeon. Okay, you will tell me which option it is. Option B is nothing par oral. Option C is IV antibiotic. IV antibiotic. Option D is NG suction. Option E is, suppose, inform social service, like that. Okay, so now tell me, what is the two answer? Answer any two. What is the two answer in here? Most important.
NPO.
B and D.
B and D. Very good.
Yeah.
Before calling the surgeon, as a medical doctor, you have to make sure you put the baby on NPO and then you put an NG tube. And if there is option of IV fluid, I'll choose that one, IV fluid. But there is no option, so I choose NPO and NG suction. I did not choose IV antibiotic. I did not choose call the surgeon. Because before calling the surgeon, they said, what is the immediate management? They did not say, what are the all management? I will call surgeon, but after I make sure that the baby is NPO, baby is NG suction, baby has IV fluid, baby has antibiotic, then I'll call the surgeon. Okay, so this is multi-part question number 2. Then there'll be multi-part question number 3, suppose, or no. Sometimes there is 2 questions, sometimes there is 3 questions. Okay, so there'll be multi-part question number 3, that after surgery, okay, after surgery, how long the baby will put NPO? So usually 2 weeks, right? 2 weeks to 3 weeks, we put the baby NPO if there is a major gut surgery, usually 2 weeks. And after 5 days, we start total parenteral nutrition. Any baby who is NPO up to 5 days, we start total parenteral nutrition, because the baby will be malnourished otherwise. So this will be 3rd question. So this is the type of multi-part question. So multi-part question, there'll be one X-ray or one ECG or something. They will ask you what is the diagnosis, and then there'll be one investigation, and then there'll be one management. This is called multi-part question. You got my point? Any question from this question? Okay, no, very good. Now this is another EMQ, example of another EMQ. This is respiratory EMQ. Okay, here the question is about apnea. What is the type of EMQ? What is the type of EMQ comes in AKP? Do you have any idea what is the type of EMQ comes in AKP? Anyone? Do you have any idea? There is a type, certain types of question that will come in AKP. Number 1, it will be problem-based, like apnea, like convulsion, like fever, like bleeding. This is called problem-based. Number 2, there'll be investigation-based. They will give you 3 diagnoses and tell you which one is the most important investigation, gold standard investigation. So investigation-based. Number 3, treatment-based. Like which one of the following treatment you will give? Suppose palliative care, 3 drug, Movicol, Sena, okay, picosulfate, glycerin suppository, parectal wash. This is the treatment-based. They will give you 3 questions, 3 different questions, and they will tell you what is the most important drug here. Okay, so there will be problem-based question, investigation-based question, and treatment-based question. Okay, so this is a problem-based question. Apnea, this is a problem-based question. So here you can see this child is apneic. Okay, what is the first question? First question is question number 1, 6-week-old baby who has history of snuffy nose. Snuffy nose. Snuffy nose means rhinitis. In previous 2 weeks, with worsening of cough for 3 days, after it, he became cyanosed. Okay. And apneic. Good feeding, he had good feeding, but his feeding is now slow, becoming slow with cough. Baby has normal weight, no respiratory distress, but cough. What is the answer? Most of you will answer bronchiolitis because there is viral infection, snuffy nose. Okay, baby has cough and become apneic. But remember, normal bronchiolitis usually does not cause cyanosis unless it is very severe variety of bronchiolitis. And bronchiolitis will not causes by 2 weeks. It is too long time. Bronchiolitis will decline after 2 weeks. Okay. So the baby has repeated cyanosis, apnea. There is no fever, but the baby has some snuffy nose, runny nose. After that, he developed bouts of cough, worsening cough. Worsening cough is not bronchiolitis. Bronchiolitis is actually static problem. It is not worsening problem. And within 2 weeks, baby will be either improved or deteriorated in bronchiolitis, right? So it is not bronchiolitis. It is pertussis. That is called 100 days cough. 100 days cough, more than 3 months. Cough persists more than 3 months. Now you can ask me, Madam, 6-week-old. Yes, it can happen in even neonate, infant, because it is a contagious disease. Baby is exposed and baby is not immunized by pertussis vaccine, DPT. So he can have, because in UK, what is the age of immunization in UK? Who can tell me? From which age we start immunization in UK?
2 months.
2 months.
2 months.
8 weeks.
Yeah, 2 months, 8 weeks. So this baby is 6 weeks. He can have pertussis, isn't it? So this is the pertussis. Okay. Any question from this? So this is a problem-based question. So you have to understand the problem-based EMQ. Now the second question was 6-week-old baby who was delivered in 36 week. Okay. With 36 week, the baby is gestational age. This is gestational age, no need. Presented in the ER because of apnea twice in previous 48 hours. See, this is now also 6 week and there is twice apnea. I don't know what is this, size is not increasing. Wait just 1 minute, I'll put it some. The size is bothering actually. Why this size is like that? Okay, I cannot change the size, I don't know. I don't know, where is the problem? Okay, khalas. So 6-week baby who was delivered at near term, presented to the ER because of apnea within 48 hours. There was 2 apnea. He was born, he was on bottle feed and changed the formula recently. Okay, so change the formula means he was taking some other milk like cow's milk. Now he is taking some other milk. Okay, suppose hypoallergen milk. Mother found him blue in the cot and covered with vomiting. So why the baby become apneic? Because of this vomiting. What is the danger point of vomiting? It will regurgitate aspiration. Yes. She slapped him in the back and started to breathe, then call ambulance. All examination and investigation were normal apart from the faltering growth. Why the answer is gastroesophageal reflux? Why not it is pertussis? Why not it is like other variety? See, the baby has repeated history of apnea. Okay. You know, either this baby, there is an important differential diagnosis other than gastroesophageal reflux. Who can tell me? What is the important differential diagnosis of this case?
Aspiration.
Aspiration, I gastroesophageal, I agree. Then
Tracheoesophageal fistula.
one important differential diagnosis of this baby is non-accidental injury.
In NAI.
NAI, yes. Why? 6-week-old baby, repeated apnea. Okay. Although mother gave CPR and came to the hospital. But don't you think any remember, this is called LT. What is LT? Who can tell me what is LT? What is LT?
Acute life-threatening event.
Very good. Adverse life-threatening event. Apnea, convulsion, coma, breathing difficulty, bleeding. This is called LT. They are adverse life-threatening event. Any baby can die with this event. So any LT infant, you have to suspect non-accidental injury. But at last, because first of all, you have to rule out what is the cause of apnea. In this baby, non-accidental injury is a differential diagnosis, but first diagnosis is gastroesophageal reflux, because the baby is vomiting and the baby is developing apnea in 48 hours. This is without vomiting. That means there is some aspiration due to gastroesophageal reflux. Okay. And if this case, they are asking what is the next, you have to tell the differential as non-accidental injury. Okay. Any adverse life-threatening event in neonate, you have to say non-accidental injury. Why this is not changing? Okay, now next question. Next question, C. 7 days old, 7 days baby who has neonatal discharge, 7-day born neonate discharge at second day. Poor feeding, lethargy for 24 hours. What do you think? Any neonate comes with you, poor feeding, lethargy. What is your first diagnosis? Any neonate.
Late onset sepsis.
Yeah.
Remember, when a neonate comes to you, okay, you don't know what is the treatment, you don't know what is that. If you feel the baby is lethargic, not arousing, I mean, baby is not responding to you, to your voice, to your stimuli, always think about sepsis. Always. This is a common practice. Any neonate having serious life-threatening event, you have to think about sepsis, because neonatal septicemia is the most common cause of death worldwide. Okay. 7-day born, discharge at second day. So that means it was maybe NVD, poor feeding, lethargy, and 2 episodes of apnea, CBC normal, CRP 12, slightly raised. Temperature 36, hypo. What is the normal temperature in neonate?
36.5 to 37.5 degrees centigrade.
Right. So it is 36. So it is low. Heart rate is 160, tachycardia. Respiratory rate 40, okay. Partial pressure of oxygen 96%, okay. Capillary refill time 4 seconds. What does it mean? Capillary refill 4 seconds. What does it mean?
Delayed.
Prolonged.
Very good. Capillary refill prolonged. Temperature, okay, we discussed. Mild acidosis. Answer is sepsis. Do you have any confusion? Why this is sepsis? Why not apnea of prematurity? Do you think this is apnea of prematurity? In apnea of prematurity, do you think the baby will be lethargic, unarousable? No. Do you think this is head trauma? Do you think this is head trauma? No. Because non-accidental injury, we will think at last, not at first. Okay? It can be abusive head trauma, but we will not think otherwise, because the baby is not so much pain. In, see, CBC normal. In case of head trauma, do you think CBC will be normal? There'll be anemia, isn't it? Okay? So it is not abusive head trauma. It is not non-accidental injury. Actually, it is sepsis. And it is, which day sepsis? Early onset neonatal sepsis within 3 days. It is early onset neonatal sepsis. We finished this EMQ also. Any question regarding this EMQ? No question. Okay. Now see, this is, I told you that EMQ will be, how many based? EMQ will be problem based, symptom based. EMQ will be investigation based. EMQ will be treatment based. Now this EMQ is investigation based. See, hypoglycemia. This is the heading. This is investigation, hypoglycemia. Now they are giving you ulta. I mean, disease is here, but the investigation is here. In the question is investigation, but the disease in the option. So a newborn who is very good weight, see 4.2 kg, very good weight, very low RBS, no ketone. So hypoglycemia with absent ketone, ammonia 60. What is the diagnosis?
Hyperinsulinemic hypoglycemia because of
Hyperinsulinemia.
excess
Very
ketone.
good. Yes. Why not this is MCAD? Who can tell me? Why not this is metabolic disease, fatty acid oxidation defect, MCAD? Why not? In MCAD,
Ketones will be raised.
sorry.
Ammonia will be raised in MCAD.
Very good. Very good. This is 1 point. Another point.
Ketones also will be raised.
No, 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 no. In MCAD, this is absent ketone.
Is 4.2 kg.
4.2 kg. So the baby is
Good weight.
good weight. MCAD babies will not be good weight. They are metabolic diseased. And number 3, one answer left. Then I'll give you 100% mark. One answer left. Why not this is MCAD?
MCAD does not present on T1.
Very good. 100%. Who is that? Let me announce your name. Who is that? Dr. Ashfaq? Or what? Who is that? Okay.
H.
Dr. H. I don't know your name. What is your name? Sorry. Your name is written H. Anyway. Okay. So it is not MCAD because the baby has good birth weight. It is plumpy baby. Most commonly it is macrosemic baby and it is IDM. IDM babies are macrosemic, plumpy, isn't it? So it is not MCAD. Second is MCAD does not present in day 1. This is not MCAD, a newborn, just born. It is not MCAD. MCAD will present after few days when there is metabolic decompensation. Number 3, in MCAD, ammonia will be high. Here, ammonia is low. Low, not low. I will say borderline. I will say normal. I'll say normal. It is not low because up to 100 in neonate, up to 100, ammonia is normal in neonate. So now come back to this ammonia thing. There is FOLU, menomic. What do you mean by this FOLU? This is fatty acid oxidation defect. Okay. Here the ammonia level will be like 250, like that. This is organic acidemia. Here the ammonia level will be like 500. Here the liver disease. Here the ammonia level will be like 750. It is urea cycle disorder. Here the ammonia level will be more than 1000. This is called FOLU. This menomic, you have to remember that in case of metabolic disease, the ammonia will be high in fatty acid oxidation defect up to 250. Like it is average. I'm not saying absolute. It is average. In organic acidemia, it will be like 300, 400 or 500 average. In liver disease, it will be like 600, 700 average. In urea cycle disorder, it will be more than 1000. The most common ammonia disorder is urea cycle disorder because urea cycle has problem. It cannot detoxify the ammonia. So the ammonia is very high. Okay. So FOLU is the menomic for high ammonia in neonate or children. Now, according to this question, as I said, it is a plumpy baby. It is a macrosemic baby. So it is 4.2 kg. Very low RBS. So very low RBS means hypoglycemia. Naturally, when there is hypoglycemia, our ketone will be what? They will produce ketone because fat will burn. So ketone will be producing. Except this two or three condition when the ketone will not produce, like if there is hyperinsulin in the body or if there is metabolic disease like MCAD, the ketone will not produce. Okay. And ammonia will be high in case of metabolic disease, but not in hyperinsulinism. Who can tell me why there is hyperinsulinism in IDM baby? Anyone?
Because
Because
placenta
of
transfer
the
of
chronic glucose load
means,
from the mother.
insulin production in baby.
Chronic high glucose.
Chronic
high glucose.
hyperglycemia from the mother.
Chronic hyperglycemia from the mother, it will stimulate fetal pancreas and the baby will release excess amount of insulin. This is transient condition. It will go, but you have to manage this hypoglycemic condition. And it is very common in IDM baby. Because of the glucose that transfer via the placenta, stimulate the fetal pancreas. Okay, any question from this? Now the second question, see, a newborn who is 6-day-old boy, it is a boy. Whenever they give you boy or girl, that means it has some importance. And came with vomiting, hypoglycemia and hyponatremia. It is 121. Ketones, trace amount. RBS, very low. What is the level of neonatal glucose, normal glucose, neonate?
Above 2.6.
Yes, above 2.6.
2.6.
2.6 or more. Yeah, 2.6 is the borderline. So it is 1.1, very low. Lactate is 0.8. That means a bit high. 0.5 up to 0.5 is normal, so a bit high. Why they said it congenital adrenal hyperplasia? Because
Hyponatremia.
hyponatremia,
Hypoglycemia.
hypoglycemia
Hypoglycemia along
with
with
a male boy
male boy.
and vomiting. Okay, and the baby is dehydrated because lactate is high. What does it mean? This lactate high means what? Baby is dehydrated. There will be metabolic acidosis if the lactate is high. If the lactate is high, there will be metabolic acidosis. Okay, so this baby is CAH because it commonly presents in a male baby who is 5-6-day-old. Okay, newborn girl with CAH will present early, or newborn boy with CAH will present early? Who can tell me?
Newborn girl will present early because of ambiguous genitalia.
Very good. Newborn girl will present at day 1 because she has ambiguous genitalia. Parents will be anxious. Parents will come. But in case of boy, they will not come to you because there is no problem in genitalia. They will come back at day 5 and day 6 with shock. Isn't it? So it is more dangerous for a boy than a girl. A girl will be early treated, early investigated. But a boy will be late investigated, late comer, right? Now, 2-month-old, his mother came with the baby from Morocco 2 weeks ago. So they came from Morocco 2 weeks ago. The baby is 2 months and the father was studying in UK. Okay, there is hypoglycemic episode, hypoglycemic wait. Okay, there is hypoglycemic episode. Okay, 1.8 with coryzal illness. There is no ketone in the blood. Now here, the people will give you one option, that is non-accidental injury. Do you think this is non-accidental injury? Do you think this is non-accidental injury? This baby? M card. Why M card? Who can tell me why M card?
There is
Non-ketogenic
after
There is a disease.
he turned hypoglycemic.
Okay, yes. Another?
Ketones, they are not present.
Not present. Very good. And another one? If you answer this one, then it is very good. Another one?
After stress.
After stress. Very good. Very good. 100% answer. Very good. This baby is 2-month-old. There is problem in the family. What is the problem in the family? Father is studying. They are young parents. Father is studying. That means there is no income. Okay. In this kind of family, there is a chance of non-accidental injury. But I will not give this child non-accidental injury. Why? Because there is no ketone. Suppose, why in non-accidental injury there is hypoglycemia? Doctor, please mute the mics. Why in non-accidental injury there will be hypoglycemia? Because
Starvation.
Very good. Starvation. So in starvation, ketone body will be present or no?
Raised.
Yes. Very good. High. Because it is called starvation ketosis. Okay, it is called starvation ketosis. So remember, ketone body present, it is starvation ketosis. But ketone body absent with hypoglycemia, this is MCAD. MCAD means medium chain acyl, medium chain deficiency. This is a kind of fatty acid oxidation defect, FAOD. Sometimes they will give you FAOD, that means fatty acid oxidation defect. Sometimes they will give you MCAD. medium chain acyl triglyceride or diglyceride, something like that.
Okay. Acetylcholine dehydrogenase.
Yes, the full name of the enzyme. Yes, that is MCARD. So this question is very common, very, very common. The relation between the glucose and the ketone, it is very, very common. Okay. And ammonia, as I told you, FOLU, it is very, very common. Okay. So this 10 question we discussed today. Okay. How was this? Is what I mean, this kind of session is helpful for you, right? If we discuss like 10 question. So give me suggestion in the groups or in the Facebook that how can we do this kind of session. Okay. So today until now, I will finish now. And this is my contact number. If anyone interested in my course, you can join us. Or not, I will do this kind of session frequently. Okay. So that you can at least some benefited. Okay. Okay. So today up to this much. See you inshallah in next class. Thank you everyone for joining.
Thank you.
Thank you. Bye-bye. Assalamu alaikum everyone.